I was singing a song, I was picking it in, and then.
So I don't have to clicker because Justin is not here, right? That's fine. Christian is not here. Justin is not
Yeah, I can sit up there and push the button for you.
Yeah, I can do
that. Is that clock correct now? No?
It's already 8.
It's already 8, right? Okay, so we're going to go talk about, I want you to pay attention to this lecture in a very interesting way because it's a lot of nothing. Okay? This is one lecture where I will talk about a lot of stuff that you may never see, but people will test it. So, the way I laid the lecture out is basically telling you what you need to know about each of those diseases in exams. And if you're lucky, you stumble on one of them, you can actually write that up and submit it to any medical journal and they'll publish it because they're not common. Okay? So the lecture is a little bit, I'll point out where you need to pay specific attention. But generally, when you talk about restrictive lung diseases, you already know that definition now, right? So they are usually diseases that interfere with the ability of the lung to expand. Okay? And they can come from within the lung parenchyma itself or outside of the lung. So these are the two categories. Intrinsic, meaning within the lung tissue, or intrapulmonary, or extrinsic, meaning outside of the lung tissue. Okay? When it is within the lung tissue, it is also known as interstitial lung disease. Okay? Or diffuse parenchymal lung disease. What are the causes of it? Many times we don't even know what the heck is causing it. All we know is that the patient has lost their pulmonary elasticity and the lungs are not able to expand and recoil like they should. Okay? There are times that we know that they are associated with some genetic syndromes. And these genetic syndromes, they are known as phacomatosis. There's a reason they're known as phacomatosis. Phacomatosis just refers to a group of diseases that have cutaneous and neurological manifestations. So somebody could have skin tumors and seizures. Okay? That is what phacomatosis are. They are neurocutaneous disorders. And then very few occasions, intrinsic type of restrictive lung disease will have an acquired etiology, chronic aspiration. You know people that have GERD? Anyone here has GERD? Okay, yeah, I have GERD. Many times in that I will get up, I'll be coughing because my dinner is going into my airway. I have this hiatal thing and I refuse to fix. So you see, that chronic aspiration because remember, when you're aspirating, do you know what you're really aspirating? Is gastric acid. If you suck the gastric acid out and you put it in a glass and you put it in a dish and you put a piece of glass in it, it will dissolve. You know that? The molarity of the gastric acid is 1. It's a strong acid. That is why the gastric mucosa has that thick mucous membrane that protects it. And that's why it gets eroded and burned when it's exposed to that acid. It's a strong acid. So when people have chronic aspiration, it's like inhaling acid fume. Over a period of time, you're going to cause chronic inflammation, and ultimately you're going to end up with fibrosis, right? You already did pathophysiology, right? The way inflammation resolves, inflammation can only end in 2 ways. One is complete resolution, right? The other one is it begins to form granulomas because the body is not winning the battle. And then at the end of granuloma, what happens? You get fibrosis. You damage the tissue, replace it with fibrous tissue, right? So that chronic inflammation will predispose to interstitial lung disease. And then there is a bunch of autoimmune diseases, okay? Autoimmune diseases are diseases where the body, under normal circumstances, when the body immune system encounters a foreign particle or protein in the body, it recognizes it and initiates the production of antibodies against that antigen to get rid of it. So the body recognizes itself. There are unusual circumstances where the immune system goes rogue and begins to make antibodies against itself. Not just the whole body, but a specific part of the body, right? So those diseases all together, they are called autoimmune diseases because the body is not recognizing itself. You know, it's not the whole body. It could be the membrane in the alveolar membrane, it could be the skin, but whatever it is, there is a part of the body that the immune system is not recognizing as belonging to the body, and it begins to produce antibodies against it. And you know what those antibodies do? They look for the antigen, they bind to the antigen, macrophages pick them up, the B type of the lymphocytes pick them up, reduce all these chemokines, attract all these cells, cause inflammation, cause destruction. Okay, so you have all these autoimmune diseases. As far as restrictive lung disease or interstitial lung disease is concerned, you will see them in 3 categories. One that is called vasculitides. Vasculitides is a fancy name for a bunch of diseases, a bunch of inflammatory diseases of the blood vessels. I like to call them vasculitis, you know, and by definition, the plural of vasculitis is vasculitis. The only difference is instead of T-I-S, you put T-E-S, right? That is the official definition of things that end with I-S. In the plural form, you change the I-S to E-S. So under normal circumstances, you would expect the plural form of vasculitis to be vasculitis. Instead of IS, it should be ES. But for some weird reason, they call them vasculitides. Okay? So vasculitides is just the plural form of vasculitis. Okay? And that means the immune system is producing antibodies against the blood vessels. It could be arteries, in which case we'll call it arteritis. It could be veins. Don't ask me what you call it. Or it could be capillaries. But it's blood vessels generally. And then there is good posture syndrome. We'll talk about that later. And then there's a bunch of connective tissue diseases like lupus and all this other stuff. All right? Malignancy. Malignancy can cause interstitial lung disease. There are some infections like viral pneumonias, atypical bacterial pneumonia, miliary tuberculosis, pneumocystosis. That is it's a parasite, pneumocystis carinii. then endemic mycosis. We'll talk about all this down the road. These are all infections. Then occupational exposures like pneumoconiosis or hypersensitivity pneumonitis, or inorganic iatrogenic doctors, treatment, clinicians. Some medications we give patients, even radiation therapy, can actually fry the lungs over a period of time. Okay? So, right here, right now, I want you to take a look at this side of this slide. So, if it's going to be caused by idiopathic, you have to rely on other things that might clue you into that particular disease. But you would imagine if somebody has viral pneumonia, it will be an acute situation, right? Viral pneumonia, the patient will be sick for maybe 2 weeks, right? If on the other hand, somebody has occupational exposure, the history of occupation will clue you in that this might be what this is, right? So you see, any time in any class, you have a long list of causes for anything. Don't look at the list as something you have to memorize. The way you do it is you look at that list and begin to ask yourself, how would you tell these causes apart from themselves in the clinic? And you always go back to that your patient interview template and populate it in your mind. What will be in the presenting complaint that is unique to this particular group of causes? What is it in the family and social history that will be unique to this group of causes? Are you following what I'm saying to you? That is the way you're supposed to learn this thing as a clinician, because that is the way you're going to use it in practice. Don't try to memorize a list. Always put it in patient interview template. Okay? Family history, social history, occupational history, medication history. Invariably, everything anybody will teach you in medicine has to fall into those categories. So it is the best way to study this thing. Okay? You understand what I'm saying, right? Excellent. So when it is extrinsic, it is easy because it is either pleural or thoracic, and those are obvious. Pleural effusion, pneumothorax, pleural fibrosis, you will see that. It could be thoracic, and remember, part of the reason you do anatomy is so you know how the body is set up, right? When it's thoracic, it could be at the skin level, like somebody that has a complete burn around their thorax and they have burn scar. They're not going to be able to take a deep breath because these burn scars are very restrictive. Okay? Morbid obesity, restrictive devices like when women that wear corsets, right? To look, they don't have to look, right? Then cardiothoracic surgery in the acute phase when the patient is feeling pain. People don't want to expand their lungs or their thorax when they are in pain. Okay? Then you have skeletal problems. We talked about this already, right? Under restrictive lung diseases. I know we talked about it somewhere, I don't remember. Skeletal kyphosis, scoliosis, or even both, and ankylosing spondylitis. You will do rheumatology, all of this will become clearer. Okay? But many of these are due to vertebral spine inflammation. Okay? Then you have neuromuscular disorders like myelopathy, motor neuron disease, myasthenia gravis, Guillain-Barré, and muscular dystrophies. Myelopathy is a disease of the spinal cord. Motor neuron disease is a disease of the nerves that control movement. Myasthenia gravis is antibody to the acetylcholine receptors. Guillain-Barré is another one of those autoimmune diseases. And muscular dystrophies, abnormal muscle development, usually in children. All of these will interfere with the ability to expand the thorax, and therefore it will restrict the expansion of the lung, right? And then you have abdominal distension. When I was in medical school, if you want to remember what are the causes of abdominal distension, we always say 5 F's, right? It's fat, fetus, fluid, food, flatus. Okay? That is obesity, pregnancy, ascites, overfeeding, and gas. Okay? So whenever I see somebody with abdominal distension, just run through that in your mind. Sometimes it helps you, other times it doesn't. Where is Justin?
Is that a funeral?
He's off?
It's aunt's funeral. His aunt plus. That's the
Oh, really? Sorry about that. I didn't know. Okay. So, I've given you the causes of interstitial lung disease. And we say, when you say interstitial lung disease, that means disease of the interstitium, right? Then what is interstitium? See, if you look at the lung, you can divide the lung into two. Air space and interstitial space. That's it. Anything that is not air is interstitium. Okay? And if you look in the lung, so the interstitium in any organ is the supporting tissue. Okay? The tissue that hold the cells that hold the other cells in place to do what they need to do are the supporting cells. Together, those supporting cells form what is called the interstitium. Okay? In the lungs, it consists of the alveolar epithelium, not the alveoli. The alveoli epithelium. Pulmonary capillary endothelium, not the pulmonary capillary, but the endothelium itself, the lining. The basement membrane, okay, of the alveoli. The tissues around the blood vessels and the lymph vessels. We call them perivascular and perilymphatic tissues. So everything in the lung that has nothing to do with gas exchange is part of the interstitium. Okay? That is the definition, that is the image. So that you should know what the interstitium is, because we're going to be talking about interstitial lung diseases, right? So this is just a picture of the list I gave you. So I'm going to be repeating myself significantly throughout the lecture, but anytime I'm repeating myself, I'll always make a reference for you. So when you talk, remember I told you another name for interstitial lung disease is diffuse lung disease, right? And all these causes here were on my list earlier, right? Okay. So I'm just giving you, these are the groups we're going to discuss as we move forward. Now, collagen vascular disease, they're also autoimmune diseases, scleroderma, rheumatoid arthritis, dermatomyositis, lupus, mixed connective tissue, and Sjogren's syndrome. All of these are all autoimmune disorders. When you do rheumatology, you will learn more about them. Scleroderma is a very interesting disease. The patients, they look very young because the inflammation is just underneath the skin. And because of the fibrosis, it tenses the skin. So it's like somebody is doing facial surgery. So they look very young in their faces. But the problem is, as the disease progresses, the skin gets really tight and blood vessels start getting compressed. Then they start getting necrosis. Okay? So, and then rheumatoid arthritis is bad inflammation of the fingers, joints. Dermatomyositis is inflammation of the skin and the underlying muscle. Systemic lupus erythematosus is just diffuse inflammation in the body. You will talk more about this in rheumatology. Vasculitis, this is the list. You remember Church-Strauss? Right? We talked about Church-Strauss when we're talking about obstructive lung disease as a differential diagnosis of bronchial asthma. Remember that? Okay. And giant cell arteritis, Wegener's granulomatosis. We'll talk about each and every one of these. Okay, infection, mycobacterial infection, and then chronic aspiration, diffuse pulmonary hemorrhage, good pastures, idiopathic pulmonary hemorrhage. What is the point of putting this thing here? Why am I repeating myself here? The only thing I want to do with this slide is to let you know that there are specific causes of interstitial lung disease, and there are many. Okay? So what we're going to do going forward is I will take each and every one of these and I'll put it in the template of the patient interview database. That way, You don't need to memorize the list, but you will recognize it when you see it in practice because I hope you'll be able to retain the specific characteristics in your patient interview. What would the patient come telling you that will clue you into the causes of this? Nobody expects you to carry this in your head and regurgitate a list. The point of this list is just tell you it's a lot of causes. I have to talk to you to figure out what is going on. Okay? So let's take them, I think, one by one now. But no, before we do that, again, I have to talk about the pathophysiology of interstitial lung disease. I already did, in a way. All interstitial lung diseases begin with a lung injury. All of them. They begin with a lung injury, and that injury will activate the B lymphocytes. They make immunoglobulins, the antibodies, and it will activate the T lymphocytes. They make a lot of cytokines. At the end of the day, the antibodies are going to look for antigens, and once they bind the antigen, they activate the macrophages. The cytokines also activate the macrophages. At the end of the day, you get the macrophages try to do what they do, which is to recruit more macrophages to phagocytose the antigen and destroy it, ultimately. And then, in the process, they release a lot of oxidants and proteases, and the surrounding cells in the lungs, called pneumocytes, they get damaged. There are two types of pneumocytes in the alveolar wall. There is pneumocyte type 1 that are actually supporting cells of the alveoli, and there are pneumocyte type 2 that produce the surfactant. Okay? That detail is unnecessary. I'm just giving it to you if you want it. And then there are fibroblasts. These are the problems. Do you see that the fibroblasts are activated two ways, directly by the cytokines and also by the type 2 pneumocyte cells? They are the ultimate problem because it's the fibroblasts that form the fibrous tissue. It's the fibroblasts that will replace the normal tissue with fibrous tissue and create the interstitial lung disease. Okay, so if I ask you, yes, inflammatory cells are important in the initiation of interstitial lung disease, but the cells that actually seal the fate of interstitial lung disease are the fibroblasts. Without the fibroblasts, there will be no fibrosis. Okay? You can still get inflammation, right? It's the fibroblasts that promote the fibrosis that creates the problem in interstitial lung disease. All right? How does it present? Now, this is where I want you to pay attention. You see that list of long, complicated causes of interstitial lung disease? It does not matter. All patients with interstitial lung disease, they come to you with shortness of breath. All of them are short of breath. Some of them will have cough if the cause of their interstitial lung disease is irritating the airway. Okay? And if they are so short of breath that breathing becomes a workout, they will lose weight. They will lose weight because of increased energy expenditure and because they are not going to be able to eat. Because when you're short of breath, you don't want to eat. You have to hold your breath to swallow. If you're short of breath, you can't afford to hold your breath. So they eat less. So the weight loss is twofold. From the dyspnea and from the inability to eat, reduced intake. When you examine them, all of them will have respiratory distress. And you already know what that is. Respiratory distress is tachypnea and dyspnea. And any time you have hypoxia for a long time, you'll get digital clubbing. So when you look in their hands, what is that window? Good. Yeah, they'll have digital clubbing. Now, they have a very interesting quality of crepitation. Remember in pulmonary edema, what does the crepitation sound like, actually? It's fine, right? When it is pus inside it, it is coarse. So in pneumonia, you get coarse crepitation, right? In pulmonary edema, because it's a mixture of air and water, is fine. It sounds just like you roll your hair in front of your ear. That's the fine crepitation. Okay? Do that. You see how it sounds? Yeah, that is fine crepitation. That is how the lungs, when the patient inhales, under normal circumstances you will hear, but when there is fluid in the lungs, you still hear the inspiratory sound, but now you hear this other sound that is just a reflection of fluid shifting within the expanding alveoli. When it is fluid, the sound is fine. When it is pus, as in pneumonia, it's coarse, right? Now, when it is due to interstitial lung disease, you know those Velcro strap, when you put them apart, they make that horrible sound? Exactly. Do it again. Exactly. That is exactly how the lungs sound when there is interstitial lung disease. Like you're opening the Velcro. So, a good example for your internal medicine 3 exam will be to match quality of crepitations with underlying pathology. Fine crepitations, coarse crepitations, Velcro, and you match them and what is the likely cause of it. That would be a good question. All right. You see, do you see how non-specific this will be? I mean, shortness of breath. Are you kidding me? There's so many causes of shortness of breath. But that is all your patient will give you when they have interstitial lung disease. Cough, some weight loss if you, respiratory distress, digital clubbing, Velcro sound. None of this is specific. But if you are an astute clinician, you will take a good history. Now, depending on what your patient tells you, you will do some specific tests, and you will ultimately arrive at your diagnosis. Okay? So, the test you do in patients with interstitial lung disease depends on how good a history you've taken, your history of your presenting complaint. Then that will direct your test. Chest x-ray, what you find on chest x-ray, again depends on what is causing it. If you send them for lung function test, yeah, you will come back with a restrictive pattern, you know all about that, right? And depending on whether it is intrinsic or extrinsic, residual volume may be decreased or preserved, right? If it is extrinsic, residual volume will be preserved, right? If it is intrinsic, residual volume will be reduced. Remember? Okay, good. And I always tell, I told you, DLCO will be normal in patients with all extrinsic causes. So if you find somebody with shortness of breath and you've examined them and there is nothing, the only thing is that they're short of breath, maybe they have coarse crepitation, and you send them for lung function test and they exhibit a restrictive pattern on the lung function test, on the spirometry, and reduce lung volumes that you will expect in a restrictive lung disease, and then they tell you the DLCO is normal, you know your patient doesn't have a lung disease, he has an extrinsic. There's something interfering with the ability of the lung to function. The disease is not in the lungs, right? Excellent. All right, so why is it important to know this? You know, you never know where you find yourself. Say somebody, I don't have time, I'm going to distract. Okay. So, earlier on I told you that what you find on the chest x-ray depends on what is causing it, right? So this is the x-ray of these are some of the diagnostic radiographic patterns you find on chest x-ray of patients with interstitial lung disease depending on what is causing it. What is the name of that professor that comes in the night? Huh? Vahidi, yes. He must have told you about interstitial lung markings. They could be increased. When they're increased, that is what we call them fine reticular interstitial markings. It could be coarse when they are thicker, right? Or it could be like rice grains on the chest x-ray, like it is here. We call it fine nodules. They are nodular, but they could be fine, as in small, or they could be in masses, okay? Usually, the radiologist will send a report to you, and that report will say, oh, there is fine reticular interstitial mass, interstitial infiltrate, or multiple nodules, or fine nodular infiltration. That's what they will say. You now have to take that and plug it into a scheme. When the infiltration, when the pattern is nodular, usually that is what you see in sarcoid. Sarcoidosis is a common cause of that. There is another group of diseases called histiocytosis X. Rheumatoid arthritis, if you have lung involvement, will present as nodular infiltrate. Infections, all infections, whether viral, whether endemic mycosis, does not matter. They present as nodular. If there is malignancy, so somebody has colon cancer with metastasis to the lungs, it will present as nodular. If there is pneumoconiosis, pneumoconiosis is the name for occupation-related lung diseases. It looks nodular. I know if you look at this, it spells shrimp, right? Now, if your patient has hilar lymphadenopathy, you see, this is the hilum. This bulge that you see here, they're not normal on normal chest x-ray. Whenever you see this kind of bulge on the chest x-ray, this one, normal hilar is supposed to be here. This additional thing here is a problem. That just means that the lymph nodes in the hilum is that part of the lung where the pulmonary artery, the bronchial artery, the lymph nodes are going into the lung tissue, right? So it's called the hilum. When you have hilar lymphadenopathy, again, you should think about sarcoid, malignancy, infection, pneumoconiosis, especially silicosis and berylliosis. All of this, don't worry, will become clear as we go forward. If there is pleural thickening and calcification on chest x-ray, almost always your patient has been exposed to asbestos. Okay? What I was going to say earlier that I stopped myself was the fact that many of these conditions here, you're not going to, very few of them you're going to treat in practice. Most of them you're going to be summoned as a witness, to provide expert testimony on whether the patient has a claim. There are people that will claim that because they work in the glass industry, that's why they're short of breath, right? But then you do and they are suing the company, right? And you're their primary care provider. And sometimes they will call you to court to say, tell us, do you really think this is the case? And you can say, well, you know, the GLCO is normal and from my training. That means his shortness of breath has nothing to do with this lung disease. That does not mean he does not have a lung disease as a result of exposure to asbestos, but that has not caused his shortness of breath. Because if that is the case, his DLCO would have been normal. You know, these are the kind of things that you get yourself into, right? That's why more of this information you will actually use in those kind of settings than in clinical setting. Because for 75% of these diseases here that we're talking about, there is no specific treatment. And even if there is treatment, you're not going to be able to do it. It's somebody else. You'll send them on and watch. When you look at the x-ray and there is upper load predominance, TB, but it could also be endemic mycosis, silicosis, sarcoid, or histiocytosis. TB, don't ever forget that. When it is lower lobe, predominant, aspiration, idiopathic, and autoimmune diseases is more likely. So this pattern that I'm giving you here, you really need to know them. You don't need to know the causes of, all the causes of interstitial lung diseases, but where there is a specific pattern recognition sign, you should know that particular one. Because if you don't know it, it will be, I test it. Let me just say that. Now, so let's say your patient has interstitial lung disease as a result of connective tissue disease, right? Remember all those connective tissue diseases, disorders that they that long list, lupus, rheumatoid, connective tissue, connective tissue, gangrene that we have there, right? When your patient presents to you, they will present with signs and symptoms of connective tissue disorders. And the way they present is a lot of joint pains. You see, arthritis is inflammation of the joint. Polyarthritis is inflammation of many joints. Okay? And then myalgia is muscle ache. Polymyalgia is muscle all over the body aching. Dry eyes and dry mouth, Sjogren syndrome. Okay, you see old people, they don't. Sjogren comes with age. If you live long enough, you will have Sjogren's. Okay? Dry eyes, dry mouth. Dysphagia is usually because of dry mouth. Okay? They have skin rash and they have Reynolds phenomenon. You know what Reynolds phenomenon is? Exactly, when you put it in a cold environment or you try to get something from the freezer and you get pain because of vasoconstriction in response to cold, right? Okay. And when you examine them, you could see facial erythema, sclerodactyly, lymphadenopathy. Laboratory test, you always do a CBC, a complete blood count, and you will see leukopenia or thrombocytopenia. And many times the reason you see this leukopenia and thrombocytopenia is because the white blood cell production is being drafted towards the immune system, and sometimes antibodies are actually produced against those cells, right? So you have leukopenia, thrombocytopenia, and now as a screening, so once you see your patient comes to you with shortness of breath, and then they have a history of, say, lupus, then you're lucky, because then you begin to think, well, this shortness of breath might be connected to your lupus as a result of interstitial lung disease, right? I'll say the patient did not know they have lupus, but they have shortness of breath. Then you start reviewing their system. When you're reviewing their system, you find out they have a lot of pain, many days. They have muscle, body ache that has been going on for years. They have dry mouth, dry eye, they have difficulty swallowing. You look at the skin, you see rash. You're thinking this could be a connective tissue disorder, right? But you don't know which one it is. So generally what you will do is to order 2 tests. Rheumatoid factor and anti-nuclear antibody. Oh, sorry, anti-neutrophilic antibody. Okay?
So what's with the restrictions?
Huh?
What is restrictions?
Yeah, I'm coming. Right, so you do those tests, rheumatoid factor. You see, rheumatoid factor was first discovered in patients with rheumatoid arthritis, right? We thought, oh, once they have rheumatoid factor positive, then it's rheumatoid arthritis. We're dead wrong. When we started looking at other connective tissue disorders, we found out that they also exhibit rheumatoid factor, right? So, although rheumatoid factor for rheumatoid arthritis is up to 85% sensitive and 95% specific, if your patient has rheumatoid arthritis, rheumatoid factor will be there. But you can also find rheumatoid factor in polymyositis, 61% of the time. In dermatomyositis, 61% of the time. In rheumatoid factor is this one. ANA, you find in rheumatoid arthritis, but you can also find in many other connective tissue disorders. ANA is not as specific for any one disease as rheumatoid factor is. Okay? I made a mistake. by talking about this as rheumatoid factor. No, this is for anti-nuclear antibody. Okay, so we do rheumatoid factor and we do ANA. And ANA specificity and sensitivity is listed here. Now, the reflex is the way you will normally order the test is you will say you want ANA with reflex. What that means is since ANA is not specific for any one of these diseases like rheumatoid factor is, the lab will now do subtyping of that ANA antibody. Because anti-nuclear antibodies, there are many. Is the antibodies to nuclear proteins. And depending on the protein they are produced against, they are divided into many subtypes. So the lab will not look for a subtype unless the ANA is positive. So when you order the test ANA with reflex, they will look for a positive ANA. If ANA is negative, the test stops right there. But if ANA is positive, then they will do other tests. They will look for anti-Jo1, and when anti-Jo1 is there, that means your patient has dermatomyositis. Or they will look for anti-double-stranded DNA, which is positive in lupus. Or they look for anti-Smith, which you also see in lupus, but is a lot more specific for lupus. Then you have this anti-U1 ribonucleoprotein that you can find in mixed connective tissue diseases. Then you have anti-La and anti-Rho. I don't like calling them anti-La and anti-Rho. I think I prefer anti-SSB because SSB means Sjogren syndrome related antigen B. And SSA means Sjogren syndrome related antigen A. Okay? Rho and La is the name of the people that worked on them, right? So you find that in Sjogren syndrome. There are two types of Sjogren syndrome. No. You find it in Sjogren syndrome, leave it alone. Then you have anti-U3 ribonucleoprotein that you find in scleroderma and anti-scleroderma 70 you find in scleroderma. Why is it important to know this? Because all the lab will report to you is positive ANA, anti-Jo1. So you have to know what that means clinically for your patient. Okay? So pay attention to this one because it's tested and I will test it. Okay? And I don't have any easy way of making it clearer to you, but let me tell you, it's not as complicated as it looks. Let's take a look at it critically. You don't need anybody to tell you anything about this one. Scleroderma is SCL70. Forget it's 70. That is scleroderma right there. Anti-Rho and anti-La, the SS is Sjogren syndrome. It speaks for itself, right? The one that don't really make sense that you have to pay attention to is this anti-U3 RNP. RNP is ribonucleoprotein, but it's for scleroderma as well, but there is nothing about it that is comparable to scleroderma. You know what I mean? So you just have to remember that, well, if it has a number to it, it's either scleroderma or mixed connective tissue. If there is a number attached to it, it's either scleroderma or mixed connective tissue. So if it is U3 RNP, it's scleroderma. If it is U1 RNP, it's mixed connective tissue. So that helps you, right? Then the rest are easy. Anti-Ra and anti-Lo, the SSB, SSA, Sjogren syndrome, they are both for Sjogren syndrome. Anti-Smith is lupus, it's very specific for lupus. And anti-Jo1 is dermatomyositis. Okay? I don't know if that helps. Yeah.
So are these the only ones? Because say you test RN factor and you get it positive, and then you do an ANA. I don't see one for like rheumatoid arthritis. So how would you? Or is there more?
The rheumatoid factor will give you rheumatoid arthritis.
So, but you don't automatically have rheumatoid arthritis if you have like scleroderma or dermatomyositis, do you?
I'm not sure I understand the question.
So like, okay, so say I have a patient, I test their RF factor. That tells me specifically that they have rheumatoid arthritis?
Yes.
Is that disorder?
Yes.
Okay.
Yeah.
So then I would have to still do the AMA to rule out everything else or no?
If they have positive rheumatoid factor
Yeah.
and negative ANE, which is rare,
Yeah.
then you have rheumatoid arthritis.
Okay.
If they have positive rheumatoid factor and positive ANA, you still pursue the specificity. You type the ANA. Most of the time, patients with rheumatoid factor, rheumatoid arthritis, will have rheumatoid arthritis positive, right? And they will have some ANA. Some of them will have positive ANA as well. But most of the time, patients that have positive ANA do not have positive rheumatoid factor. Yes, I'm saying. This test, they don't really diagnose these connective tissue disorders. They help you confirm what you're thinking. Rheumatoid arthritis is a crippling, disabling disease. When you look at the patient, you know this is rheumatoid arthritis. You will just do this test to confirm what you're really thinking. When you see lupus, you know this is lupus, right? When you see scleroderma, oh, you know. Why you? Oh, I hope you will see scleroderma in practice. You can't even pinch their skin. You can't. The skin is so tight, you can't pinch it. You know. So many of these connective tissue diseases, clinically, you will be able to tell what you think the patient is. These tests only help you confirm the impression. But you're right. If you have positive rheumatoid factor, you may or may not have positive ANA. And if you have positive ANA, usually you don't have rheumatoid factor. Okay. So remember good posture syndrome, right? Is one of the causes, right? So if somebody has good posture syndrome, how would you know that somebody has good posture syndrome? It's very simple. Good posture was discovered by Vanderbilt University in 1919 by Ernest Good Posture. That's why you call it good posture syndrome. Okay. We don't know why, like many of these diseases, we don't know why the patients with good posture have good posture. But we know one thing, that there is pulmonary vascular injury that sensitizes the immune system to the alveolar membrane. So the immune system begins to make antibodies against the alveolar membrane. And the antibody begins to attack the alveolar membrane. And unfortunately, that antibody also cross-reacts with the glomerular basement membrane in the kidneys. So the patient comes to you with hemoptysis, hematuria, and renal failure. Those three things, you just have to remember that if somebody comes to you with hemoptysis, that is why you should always develop the habit, and you have to fight it with Healthline to keep this practice. Every patient that you see, unless it's a simple, straightforward, common cold, that you tell them, oh, we'll watch and wait, you come back, see me in 2 weeks if the cold is still lingering. Or you know that the patient has migraine, and you tell them, take Excedrin, come back and see me. If it is not any one of those bread and butter clinical stuff, you must do on every single patient that is presenting to you with something that is not simple and straight. You must do a CBC, you must do a comprehensive metabolic panel, and you must do a UA. It will help you tremendously. Because you see, if somebody comes to you and says, you know, I've been coughing up blood for the last 2 weeks, and then you look in the UA and you find hematuria, well, anytime you see hemoptysis and hematuria, you must think about good posture syndrome. Okay? It's not very common. That is why you really have to have a very heightened alertness to it. Okay? Hemoptysis and hematuria in the presence of renal insufficiency, which is elevated BUA creatinine, you must think about good pasture syndrome. Because when you do the chest x-ray, this is what you see. This is pulmonary infiltrate that is due to bleeding inside the alveolar space. Okay? And then once you have this, then you can begin to order special tests. You refer them to nephrologists, not for evaluation. You tell them you're thinking that this patient may have good pasture syndrome. You want them to do renal biopsy and look specifically for anti-glomerular basement membrane antibody. Okay? And you draw blood and send the blood for anti-neutrophilic cytoplasmic antibodies. These are weird antibodies that you also find in patients with, not just in good pastures, many other of these autoimmune diseases have what is called positive anchors. Anchors are antibodies against neutrophilic cytoplasmic antigen. So if you take, they have these antibodies, if you look at what they are reacting to proteins carried within neutrophils. Okay, so that's why they are called anti-neutrophilic cytoplasmic antibodies. They carry it in serum. Okay? I wanted you to pay attention here. Nothing here is specific for good pastures, but whenever there is consolidation, I don't know if that radiologist tells you, whenever you see, under normal circumstances, you don't see the air inside the terminal bronchioles. You don't see them because the air in the alveoli overshadows that particular air, so you don't see it. But whenever the alveoli is filled with fluid, it looks whiter. The air inside the bronchioles becomes visible, and you can actually see the bronchioles as a straight line of dark air. Whenever that happens, we call it air bronchogram. So it begins to look like a special X-ray done to highlight the bronchioles, but it's because the alveolar wall, the alveolar sac is filled with fluid. So if you look at this X-ray, I want to make sure I just talk about it. You see these lines right here, these dark lines, those black lines that you see across that they look like bronchioles. You could tell they are bronchial division. You don't see them on normal X-ray. The only reason you could see these air bronchograms is because the alveolar has fluid in it. So it's providing you the contrast to see the bronchioles. That is a digression. It's not part of my lecture. So what do you see on lung biopsy, on renal biopsy, not lung? Actually, you can actually do both. But generally we do renal biopsy, right? So what you see is you have antibodies against that antibody that is in the patient's biopsy specimen. You attach a dye to that antibody and then you expose the specimen to your own antibodies. Did you understand what I just said? So the patient has antibodies against glomerular basement membrane. Okay, so we do a special test. We produce an antibody against that antibody, right? That antibody that we produced is against the antibody the patient is producing against the basement membrane. We now attach our own antibody to a dye, and then we expose that dye antibody complex to the biopsy specimen. The reason we attach a dye to it is we want to know where our antibody binds. Our antibody will bind to the anti-glomerular basement membrane in the patient sample. The dye allows us to see. So if you do that in a normal kidney or normal lung, you don't see anything. But if you do it in somebody with anti-GBM antibodies, you see this fluorescence. Okay, these are things you will never do, you will never see, unless you end up in a specialized nephrology unit where they do this stuff. And this is the result of anti-glomerular basement membrane in the lungs. When you have antibodies to the glomerular basement membrane in the lungs, you just knock off the capillaries and blood leaks straight into the airspace, and the alveolar space filled with blood. That's why the patients cough up blood, and that's why they have hematuria. The most important information on this slide is hemoptysis, hematuria. That should tell you the patient may have Goodpasture syndrome. You want to see whether or not in their biopsy specimen they exhibit anti-GBM, and in their serum they exhibit ANCA. Okay. ANCA is not specific for Goodpastures, but it's always good to do it. Are you with me? It's burning, right? All right. Now let's talk about vasculitis. Remember, vasculitis is another big group of diseases that can cause interstitial lung disease. How would you know or suspect that a patient has vasculitis? Look at it. Multi-systemic. This is what called, they have a multi-systemic manifestation. Because when you inflame blood vessels, there is no organ in the body that doesn't have blood vessels. So when you have vasculitis, every organ will scream. So a patient with vasculitis, they can present with a stroke. So you see a 26-year-old with a stroke. Now what? It's not diabetic, it's not hypertensive. What happens? Vasculitis. Okay? Or sudden loss of vision. I was fine this morning, I was driving to work and I lost my vision in my right eye. Vasculitis. The only other thing that can present like that is embolism. Right? Okay. I will tell you how you tell them apart. Or somebody just starts bleeding from the nose. A heart attack. A 30-year-old non-smoker Olympic athlete with heart attack. How do you explain that? Vasculitis. Okay? Abdominal pain and bloody stool. Because remember, whenever you inflame blood vessels, you occlude the blood vessel most of the time. And that blood vessel is supposed to be supplying blood to a particular organ. That means that organ is not going to get its blood supply. So there will be pain reference to that organ, or there will be loss of function of that organ. And if it happens to be a mucosa surface, it will erode. And the patient will bleed. If it's in the nose, it will be bloody nose. What do you call, there's no medical name, bloodiness and discharge, just what it is. Or you have hematuria, or you have GI bleed. Right? Epistaxis. Joint pains, if it involves the joints. Muscle ache, if it involves the joint and muscles. Then generally because of inflammation, they may have fever, headache, and weight loss. Now, if the patient presents with myocardial infarction and they are young and they have no risk factor, you might suspect it, right? If the patient presents with stroke, you might suspect it. But you know what? If the patient presents with joint pains and muscle pain, that could be from anything. The most important clinical manifestation of vasculitis that I want you to remember and never forget is palpable purpura. Palpable purpura, right here. You see, under normal circumstances, purpuric spots, they are not palpable. You see them. But when you run your finger over them, you don't feel anything. But when that purpura is due to vasculitis, you feel it like a rash. You know, purpuric spots are just pinpoint hemorrhages in the skin, right? Usually you don't feel them. You can see them, but you don't feel nothing. If you close your eyes and run your finger over the spot, you can't tell the difference. Okay? If you can feel a purpura, that is 100% vasculitis. Okay? So palpable purpura is the most specific sign clinically for vasculitis. Okay? You can't forget that. Now, if you, and also they could get positive anchor, just like good pasture syndrome. They will have positive anchor too in serum. So that's why I told you when I was talking about good pastures. Yeah, they have positive anchor, but it's not specific. Okay? Now, when you have come to the conclusion that your patient has vasculitis, there are three of them you want to find out which one it is. It's either Church-Strauss, Wegener's, or giant cell arthritis. Those are the three major vasculitis. And I mean, this is like the third time I'm talking about Church-Strauss, right? Church-Strauss, we talked about in obstructive disease as a differential diagnosis of bronchial asthma. Remember that? So whenever you see somebody with palpable purpura with a history of bronchial asthma, then you should be thinking that this may in fact be Church-Strauss if your patient has skin infection, ecchymotic plaques, because in Church-Strauss, their manifestation tends to be significantly on the skin. Okay? So if I give you a picture, paint a picture for you of somebody with a history of bronchial asthma presenting with multiple skin ulcers and palpable purpura, I said the most likely diagnosis is, you should tell me this is Church-Strauss, right? Because Church-Strauss is a vasculitis that is associated with allergy. You see it in bronchial asthma. It tends to have cutaneous emphasis. So most of their manifestations tend to be on the skin, okay? Now, if you talk to the patient and the patient has epistaxis, not hemoptysis, epistaxis, and you look and they have ulcers on their nasal septum, and some of them actually perforate, and then you look in their urine, they have hematuria, and they have positive anchor, then you're dealing with Wegener's granulomatosis. Now let me ask you something. Stop. Good pasture, we said hemoptysis and hematuria, right? What is the difference between good pasture and Wegener's? Wegener's good pasture is autoimmune, yes, and Wegener's is vasculitic. It's a vasculitic lesion, right? But clinically, how would you tell the difference between Wegener's and good pasture? Thank you. Extremely important. In Wegener's, it's an upper respiratory tract bleeding. So it's epistaxis, it's nasal ulcer, it's bloody nasal discharge. Whereas in good pasture, it's lower GI, lower respiratory tract bleed. They cough up the blood. It's hemoptysis. Hematuria is common to both of them. Is that clear? It's a very tricky situation. I've seen people flunk exams because of this. Yeah, because they both have something bloody coming from their airway, but it comes from two different places. In Wegener's, it's usually upper respiratory tract. So you have bloody nasal discharge, you can see nasal septum will be perforated, ulcerated, whereas in good pastures, they cough up blood. Wegener's chest x-ray will be clear, whereas in good pastures, they have consolidation because they're bleeding into the lungs. You got that? Excellent, very important. And of course, the easiest one of all is giant cell arthritis. Because in giant cell arthritis, it has a specific predilection for the temporal artery. And because the temporal artery supplies all the muscles of mastication, they have jaw claudication. When they chew, they get tired. Their jaw gets tired, right? They have what is called amaurosis fugax. Amaurosis fugax is sudden loss of vision in one eye, and usually with spontaneous recovery. Okay? So it's like a TIA, transient ischemic attack. Right? And they also tend to have unilateral headache. Okay, on that side. And when you see them, you can actually see the inflamed artery. It will be thick and tortuous. And you can rub it, it feels like a cord. Okay? Normal temporal artery, when it is visible, is collapsible and soft. When you have temporal arteritis, it becomes like a cord. Okay? It becomes thick, tortuous, and tender. Okay, so now, vasculitis. You're all clear with that, right? Any questions?
Is the treatment different for each one?
That is why I started my lecture by saying, I don't even know why we're doing this. For many of these things I'm telling you, prednisone, prednisone, prednisone. It does not matter if you misdiagnose good posture for Wegener's prednisone. So therapeutically it does not matter. But you're supposed to get some intellectual orgasm from just knowing, being able to tell the difference. Okay, I hate it. I don't know why we spend so much time talking about these diseases. Clinically, doesn't make a difference, right? So, that is vasculitis. Please remember that. Wegener's and good pastures, very important. So I'm done with vasculitis. I'm now going to infection. So if your patient has infection, as a infection causing interstitial lung disease, what would they present with? Fever. Wherever there is fever, there is infection. Okay? So it is usually a subacute illness with low-grade fever, headache, and body aches. They will present with cough, but generally speaking, the sputum production is scanty. Can anybody tell me why the sputum production is scanty? Why is the sputum production scanty in interstitial pneumonia? Because the inflammation is not inside the alveoli, it's outside of it. Right? The reason the other pneumonias give you cough productive of sputum is because the inflammation is inside the alveoli. Right? The pus is inside the alveoli, so you can cough it up. In interstitial pneumonia, the inflammation is outside of the alveoli. So the sputum production is very scanty. Okay? So if somebody tells you, well, if a patient has cough and they have no sputum, that means they can have pneumonia, wrong. If you have interstitial pneumonia, you will have pneumonia, you will have cough, and it will be a dry cough. Okay? Or somebody tells you, you never need to do chest x-ray in patient with dry cough. Wrong. Most of the time, interstitial pneumonia is a dry cough. And you will not see it unless you do chest x-ray. Okay? So, in the patient interview course, you didn't talk about symptoms and how to differentiate them, you didn't? All right. I need to review that. Yeah, correct. Okay, so, cough.
What do you mean by scanty?
Scanty as in really, do you cough up anything? I say nothing, little.
Oh, okay.
Small, very small to non-existent.
Okay.
Right? Whereas in pneumococcal pneumonia, oh my goodness, they have that pink sputum that they say is, and when they have bronchiectasis, it's copious, a lot. So whenever you ask a patient, or a patient comes to you and say they're coughing, you are required to ask them, do you cough up anything? They say, no, then it's non-productive cough. They say, oh yes, that's a productive cough. The reason we ask that is because if it is an interstitial pneumonia, there will be no sputum. Whereas if it is a lobar pneumonia or something inside the alveoli, there will be sputum and they will cough it up. And the color of what they cough up actually tells you the nature of what is going on in their lung. Okay? Yeah.
Just clarify, the scanty sputum is, you are having a cough, but it's small.
It's small to non-existent. Yeah. Scanty. Because remember, every single one of you can cough up sputum. If I ask you to cough up sputum now, all of you will cough up sputum. Right? Is there anyone here that cannot give me sputum right now? There's nobody here that can. Right? So in other words, there is sputum always. All you need to do is cough, it will come out. Right? So that's why I say the sputum production in interstitial pneumonia is like the normal one that you will cough up. But when you have a lobar pneumonia, something within the alveoli, that sputum itself will induce the cough and it will be copious, not scant.
Although what?
It will be
Below pneumonia. Yeah.
a lobar pneumonia where the pus is inside the alveoli. The inflammation is inside the alveoli. Okay? So now you've decided that your patient has an infection that is causing the pneumonia. What other information can actually help you identify the possible cause of that pneumonia? If you are dealing with somebody who is HIV positive and the last CD4 count was 50, you know that is an immunocompromised patient. In that particular patient, you are most likely dealing with pneumocystosis. Okay? Pneumocystis carina is a special, pneumocystosis is caused by pneumocystis carina. It is found only in immunocompromised people. Okay? You see what I'm saying to you? So that is the way to remember pneumocystosis as a cause of interstitial pneumonia. It's caused by pneumocystis carina. It is seen in immunocompromised people. So your patient will present with low-grade fever, cough, with or without maybe little sputum. They will have body ache. But most importantly, they will be immunocompromised. Either they're on chemotherapy or they have HIV or something else going on. They're immune compromised. But what if I tell you that, okay, this is somebody that just moved to LA from Mississippi? Then you ask yourself, okay, remember what I said? Under the list of infection, we have endemic mycosis. Mycosis are fungus, right? Mycosis are fungal infections. In every environment, there are resident fungi. Okay? So in California, we have cocci. So if you were born and raised in California, you've been exposed to cocci. Your body has learned to keep cocci at bay. So even when it comes into your system, your immune system arrests it and tuck it away. And you never get sick from cocci because you've been exposed to it from childhood, right? It's like when I go to Africa, everybody says, malaria! I am the son of malaria. Right? You know, because as a kid I got it, so I'm the son of the soil. You recognize me, you just say hi, I go malaria. But if you come with me over there, the malaria will have a feast on you, right? So you see, and by the way, you know that was how the Nigerian independence came, right? Nigeria was a British colony. And when the expatriate came and they were sending all this Lord Lugard and everybody to rule the people, they were getting sick of malaria. And you know, when you're an adult and you get exposed to malaria, you don't get the regular malaria of body ache. No. The malaria invades every single tissue in your body, including your brain. So many of them end up with cerebral malaria and they're dying. So nobody wanted to come to Africa, especially West Africa. Now we can't go there. Why do we need to hold on to it? So they started signing independence for many of those West Africans. So thank God for malaria. So when you're in born and raised in California, you're already exposed to cocci. If you're born and raised in Mississippi or Georgia, they have histoplasma capsulatum. That is their own body. We have coccidiodome. Very horrible. Like I always, but it's coccidiodome mycosis, right? In this environment. So if you relocate, say you relocate to Mississippi from California, you are going to be encountering histoplasma for the first time. And it's going to knock you off your feet. So you present like a little cold that is not going to go away, lingering longer than it should. And then you x-ray, you will find it infiltrating your lungs. And then you just need to talk. Are you from here? You say, no, I just came to school here. I'm 2 weeks in Alabama. I say, oh, okay. Then you should begin to think, you're from California, right? So this could be histoplasma. And if it's the other way around, it could be toxic. So you see why the first course you take is patient interview. I know it probably didn't make a lot of sense when you were doing that course, but it is the most important course. Because it does not matter what you know. If you cannot get it out of your patient, the right information so you can put it in your template, you're not going to make the right diagnosis. And if you never make the right diagnosis, you're never going to be a good clinician. So that patient interview course is extremely important. I want you to, every lecture you go to, as you listen to lecture, talk about causes and manifestations, always plug it back into that patient interview scheme as to where in the history will this come to me, right? Extremely important. So that was what I was talking about, endemic mycosis. Then when you examine the patient, there is nothing specific. You just see pneumonia, you do chest x-ray, you may or may not see infiltrate. But when it is due to infection, you will see these diffuse bilateral infiltrates like we talked about. Remember, they are infiltrates in the interstitium, okay? How do you often, if you say you were so badly trained as a mid-level that you miss the patient immune compromised status, or you miss their recent travel or relocation, and you treat them like it's a regular pneumonia, if pneumonia doesn't get better in 2 weeks, you have a different diagnosis. You've missed the point. Okay? I hope none of you will miss cocci or histo. That's why you're having this class, and that's why I'm taking my time to explain this, because this is actually something you might see. I mean, one of our students from Mississippi got sick from cocci before, right? So it is actually likely that you see this, okay? Extremely important. Yeah.
Quick question. So to differentiate cocci and histoplasmosis, we have to know all the states in the Southwest and all the states in the Southeast.
Exactly. I mean, Southwest. Yeah. I mean, not. Just remember the blue states and the red states.
Ask them, what are they both there?
I mean, usually, Southeast, Southwest, Southeast, Alabama, Georgia, Florida, Mississippi, Carolinas, North and South. And over here, we're just with the Arizona people and Las Vegas, right? I mean, it's not difficult, And many times people know when they're from the South. If you see Southern women, they have very different attitude. The way they talk differently, they act differently. So if somebody comes to you and first of all they greet you, and you're talking to them, and they tell you about cough, and they're using very polite terms, you'll be bound to ask, where are you from? Because Los Angeles women talk differently than people from Alabama. It's true. You really need to encounter this. I mean, a lot of difference between these two groups of women and people, even their men. So you really have to know about Southeast and Southwest.
Dr. Martins, would you do continue future testing, more testing?
If you suspect it, and you're in the right place, you can send the sputum to, if you have it, to the lab and tell them you're looking for cocci, but they will laugh at you. Or for histo. You can actually culture it in sputum. The reason we don't do that is because, remember, the cough is non-productive, the sputum is scanty. The only time we do it is if the patient is in the hospital, we can now get the respiratory therapists to come and induce the sputum. And the way they induce the sputum is they have the patient inhale saline, and then they put one tube down there and aspirate. It's crazy. And you know what? The most ridiculous thing is that even if you succeed in getting this sample and sending it, it takes about 4 weeks. So your patient is already good and gone. And then the result is coming. Say, oh, thank you. But you just wasted money and effort. Okay, so we don't generally do that in these cases. That is why it's extremely important to have the information so you can make the right diagnosis and think about it. Because think about it, if you think somebody has histoplasmosis, instead of giving them Keflex, you'll be giving them antifungals, right? That could save a lot of time and a lot of money. All right, moving on. Now let's talk about phacomatosis. There are two groups of phacomatosis. There is neurofibromatosis and tuberous sclerosis. Anybody seen neurofibromatosis before? I'm sure you have. It's so common. You see people with a lot of lumps and stuff on their skin and faces sometimes. As a matter of fact, I will encourage you to go, when you have your time, go to Google and put neurofibromatosis. You need to see this stuff. Okay, you can't afford to miss it. Okay, a lot of lumps. Sometimes it's very mild, and they may only have café au lait spots. Café au lait just means coffee with milk spots. And it's everywhere. They have bone defects and scoliosis. When you look in their eyes, the black of their eyes have these dots called leash nodules, and you can actually have optic nerve tumor, right? Neurofibromatosis is also known as von Recklinghausen disease. Okay, it's an autosomal dominant mutation. That means if your parents have it, you will get it. That is why it's common. Why are we talking about it? I don't know. You can't do anything about it. But you need to know that the problem with neurofibromatosis is actually a mutation in tumor growth suppression. There is a protein called neurofibromin. It's a tumor suppressant. So when you have mutation in that gene, you are not able to form that tumor suppressor protein. So you form all these tumors. Okay, I think that is important to know. And then tuberous sclerosis, also known as Bonneville-Pringle disease, is called a complex because, again, another autosomal dominant mutation, and TSC is tuberous sclerosis complex 1 and 2 genes. Again, tumor growth suppressor protein are mutant, harmatin and tuberin, and they form tumors everywhere. Tumors everywhere. I mean, 70 to 80% of them have subependymal nodules, tumors, giant cell astrocytomas. Sometimes tumors are huge, they call them tubers. And then in the eye, they have hematomas. Tumors everywhere. We don't have a lot of time, but usually what I would do is have the class, we'll do a symptom exercise. Tell me how your patient will present if they were to have facial angiofibroma and stuff like that, but I'll skip that today because I don't think I'll finish if I do. Any question on this? It's important. You must know, you need to know that neurofibromatosis, they have café au lait spots and then they have leash nodules. You need to know that. Okay? And it might be helpful for you to know that they are both associated with mutation of tumor suppressor protein. Neurofibromin in neurofibromas, harmatin and tuberin in tuberous sclerosis. They are both autosomal dominant disorders. Okay? Drugs. Drugs can cause interstitial lung disease, right? Look at the list of drugs. Antimicrobial agents, amphotericin B. We used to call this amphotericin when I was across the street because everybody you give it to end up with some kidney toxicity. INH. You remember we give INH to anybody with positive PPP, right? Nitrofurantoin, an old antibiotic we used to use. Sulfasalazine we still give to people with inflammatory bowel disease. Look at it, aspirin, NSAIDs, gold, these are anti-inflammatory agents. I mean, seriously, look at the kind of beta blockers, ACE inhibitors, hydrochlorothiazide. The list is endless. That is why in medicine, we constantly juggle risk and benefit all the time. Risk, benefits, risk, and benefits. If I don't give you that one dose of aspirin every day because I'm afraid of interstitial lung disease, then you might end up with a stroke or a heart attack. Right? So the point of this slide is not for you to say, oh no, you have interstitial lung disease, stop all blood pressure medication, stop all aspirin, stop all. Then your patient, yeah, and they may not recover from the interstitial lung disease. The only thing is that they will have an autopsy diagnosis of a massive heart attack. Right? So,
Dependent on dosage as well.
no, it's exposure. It's exposure.
So even if we give somebody 80 milligrams of aspirin, they could still.
It's not. Remember, many of these injuries are immune-based. Right? So it does not depend on the volume of the insult. It's the immune system. Once the immune system picks it up, that's it. Right? Okay, so just know that there's a bunch of medications that can cause it. That is why one of the things I hope you also do as a clinician is every time you see patients and you're reviewing their medication, if I see you as a new patient, you can be sure I will reduce your medication by at least 2. I hate giving people medicine, especially when they don't need the medicine. And then some clinicians, for every single complaint the patient has, they throw a pill at the patient. These pills are not candies, they have serious side effects. And the more of them you take, the more likely you're going to get hurt. You know? So one of the things I want you to develop as you're getting trained is understand the side effects of medications and also understand the benefit of the medicine. So you can comfortably say, you know, I know why they gave you this medicine, but I want you to stop it because I want you to use X, Y, Z. Many, many times I don't give my patients cholesterol medication unless diet has failed. The only exception to that is if they've had a stroke or they've had a attack. Most of the time I will just talk to them on diet and what they're doing. And once people understand, they do the right thing. Nobody really wants to die. Everybody wants to live. Give them information. So that's the point of that slide. This is the occupational exposure. They're all occupational exposure. You can divide them into 2 categories. There are inorganic dust exposures and organic dust exposures. The ones we call pneumoconiosis are due to inorganic dust exposures. Coal workers, they get exposed to carbon particle and they end up with coal worker pneumoconiosis. People that work with stones and sandblasters and foundry workers, they get exposed to silica and they end up with silicosis. Both silicosis and coal worker pneumoconiosis are pneumoconiosis. Pneumoconiosis is the name for interstitial lung diseases that result from inorganic. Hypersensitivity pneumonitis is an interstitial lung disease that comes from organic dust exposure. So we're talking in terms of farmer's lung because of exposure to hay and grain dust. Bagasosis because of exposure to sugarcane fibers. Okay? Or bed breeders' lung disease because of exposure to bed feathers and droppings. That is why it's extremely important when you are taking family and social history to find out if there are any pets in the house. You ask for pets, you ask for pests, ask for any sick person around you at home, stuff like that. Extremely important. Because you know what? If somebody comes to you with shortness of breath and X-ray shows that they do in fact have interstitial lung disease, and they keep coughing and being short of breath, and you keep giving them antibiotics, and then you say maybe this is one of those that will not respond to antibiotics, and after 6 weeks, they keep coming back, taking time off of work. And then you now say, okay, maybe we'll give steroids. Now you give steroids and then nothing happens. Then they now come to you with a wound. You say, what happened? They say, oh, my bird pecked me. Oh, you have birds? That should have been part of your patient interview database. If you had asked them the first time you saw them, birds, oh, and you clean them yourself, how many birds? Then you might be able to make headway. Do you know that people have lost their jobs because they have too many doctor's appointments? In this, our environment, people have been fired from their jobs because they had to go to doctors so many times. And the employers can afford that. So there is a lot of ripple effect when clinicians are not good. That's why I want you to please, to be the best you can be, just be diligent. Do due diligence every time you see patients. Okay, so occupational exposures is easy. Shortness of breath, occupational history is positive. Or the pet history is positive. Does not matter. There are people that sell birds too. I used to live by one store where they sold birds. I used to wonder. Now, sarcoidosis. Sarcoidosis is a very interesting condition because it's pretty common, actually. Well, not pretty common, it's common. And sarcoidosis is really a systemic disease of unknown origin. And what is unique about sarcoidosis is that when you actually take a biopsy of the lesion, do you know what a granuloma is? Did you guys talk about granuloma in pathophysiology? No? Okay, you need to know what this is. So usually, when there is insult in the body, the first cells that go there are neutrophils, right? They come and they surround and they start with tissues. And then, right after the neutrophils, the monocytes. You know, when the monocytes leave circulation, it becomes what?
Macrophage.
Exactly. The macrophages, they come. They are there for repairs. Right? Actually, they're the cleanup crew. They're there to suck up the dust and stuff like that. And then they now release the chemokines that bring the fibroblasts, right? So you have the battle zone, where the bug and the neutrophils are slugging out. You have the macrophages cleaning up after them, right? And then you have the fibroblasts ready to replace any lost tissue with fibrous tissue. That entire thing there is a granuloma. Okay, so a granuloma is like an inflammatory mass that consists of a necrotic center followed by an indurated and fibrotic tissue around it. That's what a granuloma is. Usually for a granuloma, the center is soft because the center is where the battle is going on. The bug is producing toxin, killing the cells. The neutrophils are fighting back with their own technique. So the center is usually very soft and the surrounding tissue, so it becomes increasingly firm as you go from the center to the outwards. So most granuloma have what is called a caseating center. The center is soft. But interestingly, when you do the biopsy in sarcoidosis, you see granulomas and you don't see that soft center. And because you don't see that soft center, the granulomas you see in sarcoid are called non-caseating. You got that? The softening of the center of the granuloma is compared to caseation, like milk formation, basically. But in sarcoid, you don't find that. Why is it important to do this? Because many times when you see sarcoid patients, they will frustrate you. They have what looks like a simple problem, but they will not respond to anything. See how they present. Many of you will mistake this for acne in practice. And you will send them and prescribe very expensive acne preparation, but they will never respond to acne preparation, right? But when you now send them and send it, or you can even do skin biopsy and send it to the lab comes back and say, oh, non-crescentic granulomas. Then you know you're probably dealing with sarcoid, right? And what is the treatment? Steroids. All right. But if you're lucky, your patient can present with these lesions over here. This one is called lupus penial, painful skin sores on the face. It looks like pimple, but they're not pimples. Okay? Remember I told you sarcoidosis is a systemic disease. It's a systemic disease. So they have lesions in the brain, they have eye lesions, they have a large lymph node, they have heart complications. So this is not a mild disease, okay? You have to pay attention to this. And it can also affect the lungs. And when it affects the lungs, we actually stage it. And let me show you how we stage it. So what is this called? Lupus penial, okay? Don't forget that. Lupus penial for sarcoid. The way sarcoidosis presents on chest x-ray depends on the stage of the disease. Please, you do not make the diagnosis of sarcoid from chest x-ray. You never do. But we stage it with chest x-ray. Stage 0, chest x-ray is normal. 5 to 10% of the patients will present like that. Stage 1, account for most of your cases, about half of them. You will see hilar lymphadenopathy. See, I showed you that before, right? So hilar lymphadenopathy, but the lungs are clear. Okay. Stage 2, there is hilar lymphadenopathy and there is infiltrate in the lungs. That is your B right there. Okay. And then stage 4, which is the stage 3, we have interstitial infiltrate without hilar lymphadenopathy. And then stage 4 is fibrosis. You know what is interesting about sarcoid? When you do the serum level of ACE, they have elevated levels of angiotensin converting enzyme. Okay? And they tend to have elevated vitamin D. Because in the granuloma, they produce 1-alpha hydroxylase. Okay? You know, remember one. You know 1-alpha hydroxylase? No? Okay. You know anything about vitamin D? You know that when you eat vitamin D, the first place it goes to is the liver. In the liver, it is converted to 25-hydroxy-D. So basically, the liver takes an hydroxy group and puts it in the 25th position on vitamin D. That vitamin D is not active. It's stored in the liver. Your vitamin D does not become active until another OH group is added to it in the first position. The active vitamin D is the 125 dihydroxy vitamin D. That is the active vitamin D. In sarcoid, the granuloma has that 1-alpha hydroxylase enzyme. So they tend to overactivate vitamin D. And one of the things that will do is to increase the serum vitamin D level. So one of the things that we'll talk about when we do endocrinology next semester is sarcoidosis is a differential diagnosis of elevated serum level of calcium because of that vitamin D excess. Okay, it's not that they have a lot of vitamin D; they just have a lot more activated form of vitamin D. Okay, all right, and then inflammation you can see with the PET scan. PET scan is just a scan of inflammation. Whenever there is inflammation, you will see positive PET scans and stuff. Are we good? You want a break?
Yes.
Okay. Let me see. All right. Let's take a break. 5 minutes break. Bathroom break. coffee break, whatever break.
Why is the granuloma hard in sarcoidosis?
Why is it non-caseating?
Yes.
It has to do with the nature of inflammation. Remember, the neutrophils grow to the place when it's acute inflammation. Right? When it's chronic, it's more like the lymphocytes are the one that will grow. Right? So when it's lymphocytic infiltration, it tends to be hard. And because the agent in sarcoid is not really well known, so neutrophils are not there, macrophages don't know what to engulf, so the inflammation just keeps going. We don't really know what is it that triggers sarcoid. We don't know. But we just know that they have all these granulomas all over the body, daily tissues. And your clue to the diagnosis is that acne. It looks like an acne, but it tends to be around the nose. And painful. Yeah. Huh?
Like how long?
Oh, it's lifetime, usually from the adult years. Yeah. It tends to overlap with teenage adult years. So many clinicians use it for acne, right? But the thing about acne is that acne fluctuates with periods. Acne come and go. When you're stressed, it will come. Some diet will make it worse. But in sarcoid, it's there, it's progressive, nothing changes it. Yeah. Don't remember, elevated age level, very important. Elevated age level.
It was just like
well, the alliance meeting was with Andy. And she said she was there often.
So not the other one. I think it's fine.
Yeah, it's in Long Island.
I wonder if you have those sites.
Yeah.
But he told me like before I said this. When you getting it? Yeah, so that's one That's it. The one you bought? You want to get matters though? This is fine. Use this one.
What's going on, Professor? Looking a little late. Want some coffee?
No, thank you. All right. So, I hope you're able to relate to the way I'm presenting this lecture. I'm not giving you too much details on any one disease, but I'm giving you enough clinical information on how to identify them so you can make a specific diagnosis. That is going to help you in practice, and it will help you in exam. Because most of the time, all your exams, they will tell you a story. And if you know the clues they're throwing in there, you will make the right diagnosis. If you don't recognize the clues, you won't make the right diagnosis. And for you, your exam is always about making the right clinical decision. Making the right clinical decision. So it's extremely important. Is everything I've talked about clear so far? Okay. So you know the difference between good pastures and weakeners. That is key. You know about lupus perennial, which is the painful lesion in the face, usually around the nose, right? Okay. You know about ANCA, an anti-glomerular basement membrane of good pastures, right? Okay. You know about palpable purpura. Whenever you see palpable purpura, that is vasculitis, multiple otherwise. Okay. These are just things you need to know. And I know that you will talk a lot more about it in physical diagnosis. And I'm sure that Felipe will repeat it in nephrology in summer. So you'll be fine. Okay.
I have a question. What do you mean by non-speciating?
Oh, Lord.
I missed
Don't
that.
shoot me.
Sorry, I missed it.
Remember I told you a granuloma has
It's just like
a soft center? Caseation is cheese-like.
It's like a pimple, right?
So if you look at the granuloma, in the center is soft. On the periphery is firm. That quality is as a result of difference in the kind of cells that are active. In the center, usually it's neutrophils, and they are breaking down stuff. So it tends to be, when you look at the histology of that granuloma, it tends to be soft, like cheese in the center.
Okay.
Around it is the macrophage that your cleanup guys, they want to clean up your place. So macrophages, so it will be a little bit firm. After the macrophages, the fibroblasts are moving in because they want to replace any nature of cause vacuum. They want to put fibrous tissue where there is space. Right? So as you go from the center to the outside, a granuloma becomes increasingly firm. But that is unusual because in sarcoid, you don't find that cheese-like center. So the granulomas in sarcoids are called non-caseated because they don't have that cheese-like soft center. You got it?
Yeah.
Good. You know, I may harass you when you ask questions, but I like for you to ask questions, and I will repeat myself as many times as I need to make sure you understand. Because I want people to ask you, where did you train? Because you are so outstanding. All right, so we're going to talk about, please don't forget, elevated ACE levels and elevated calcium, extremely important for sarcoid. As a matter of fact, do you know that if somebody has this come to you with a history of sarcoid, and you want to know whether their sarcoid is active or not, that is how you know. You send their serum for ACE level, and you look at their calcium. Because sarcoid is like, it's a chronic undulating illness. He has his days, and he has good days, his bad days. So if somebody has a history of sarcoid, and now they come to you with multiple joint pains, and you don't know, is this because you just gained 10 pounds? Or is it because the sarcoid is active? You send them for ACE levels and calcium levels. If those are normal, their pain is not from sarcoid. If those are elevated, their pain is from sarcoid. Okay? Remember, serum H level and elevated calcium, look at it. They are disease activity monitoring, not diagnosis. Very important. So if somebody comes to you with lupus perennial and they are 21 years old and H level is normal, calcium level is normal, that does not mean they don't have lupus. It just means, it does not mean they don't have sarcoid. It just means the sarcoid is inactive. Okay? So pay attention. Serum H level and calcium level are disease activity monitoring parameters. They are not for diagnosis. Okay? The diagnosis of sarcoid is from biopsy. All right, let's talk about amyloidosis. You know, amyloidosis, I'm going to start from this side of this. Again, it's a multi-systemic disease. It is caused by buildup of abnormal insoluble protein known as amyloid fibrils. These amyloid fibrils, there are about 30 different types of them, and they define the types of amyloidosis. I gave you examples of the ones that are common. There is the amyloid light chain that you find in multiple myeloma. When you guys do hematology, are you doing hematology now?
Yeah.
But you already talked about multiple myeloma, right? Not yet. Okay. Multiple myeloma is a tumor of blood-forming cells, right? And they form a lot of immunoglobulins for no reason. Okay? And those immunoglobulins get converted into these amyloid fibrils. And then there is this ATTR, amyloidogenic transthyretin, that comes with age. And then there is this one you find in dialysis patient. And there is this one you find with chronic inflammation. This is a lot of information. Bottom line, amyloidosis is accumulation of abnormal protein in the tissue. It accumulates everywhere. And this table right here tells you how they are formed under the different circumstances. Bottom line is there is a stimulus for producing that protein. And that protein is insoluble. That means nothing can digest it, nothing can swallow it and destroy it. So it builds up in the body. It can be due to cancer, in which case it is usually due to the activation of plasma cells. Plasma cells are B lymphocytes that have been stimulated and activated and committed to producing a specific antibody against a specific antigen. Okay, that's what plasma cells are. Okay, so they make these light chain globulins, and because these light chain globulins are overproduced, they are under-catabolized and then they accumulate. Chronic inflammation will activate the macrophage. They will release interleukin 1 and 6. That goes to the liver cells and stimulate the liver cells to produce the SAA, serum amyloid A, and that results into the disease. So these are the three separate pathways for the three I listed up here. It's a lot of information, but it's not particularly important. What I want you to remember is, how would you recognize when somebody is presenting to you with amyloidosis? That is the clinical saga I want you to remember. They come to you with fatigue. They're tired. That is not specific. What is interesting is that they have these subcutaneous hemorrhages. So somebody will wake up one morning and they have like, somebody get a black eye. It's spontaneous. You went to sleep and wake up and you have a subcutaneous, subconjunctival hemorrhage. That is hemorrhage under the white of the eye. It looks like somebody hit them, right? But it's subconjunctival hemorrhage. It could happen it's a subcutaneous hemorrhage. It could happen in the eye or it could happen in the skin. Let me ask you something. Loss. So if somebody has subcutaneous hemorrhage, they have purpura. Somebody has vasculitis, they have purpura. How would you tell vasculitis from just hemorrhage?
I guess by
the purpura of vasculitis is palpable.
yes.
When you run your finger over it, if it's vasculitis, you can feel it. If it is just hemorrhage, you won't feel it. Okay, extremely important. So they have purpura it is not a palpable purpura. Okay? And then you know what is interesting? They have change in bowel habits. The change in bowel habit could be diarrhea or constipation, or it could be diarrhea alternating with constipation. You know why that is? Why do they have diarrhea constipation or diarrhea alternating with constipation? What controls GI motility? The autonomic nervous system, right? So actually, that alternating diarrhea and constipation, you also see it in diabetics, is a manifestation of autonomic neuropathy. You know, diabetics have peripheral neuropathy that gives them numbness or they lose sensation, right? So neuropathy can present with numbness, irritation, right? Where the nerve is responding by increasing its activity, or it just dies and it stops working. So a neuropathy can present with increased nerve function or the nerve dies. Autonomic neuropathy in the GI tract presents with diarrhea when the nerve responds by increased activity. So the diarrhea of autonomic neuropathy in the GI tract is comparable to the paresthesia, the numbness of the peripheral nerve. And the constipation of autonomic neuropathy in the GI tract is equivalent to the anesthesia, the loss of sensation a diabetic will get. So they are all neuropathies, forms of neuropathies. You understand what I'm saying? So when you have amyloidosis, the amyloid protein is deposited inside the nerves. It begins to interfere with the function of that nerve. And the way the nerve will respond is either to quit working or to scream. The screaming is what we call paresthesia, numbness. You quit working, the patient will start losing sensation. When that happens in the GI tract, the irritated autonomic nervous system in the GI tract will give the patient diarrhea. When the nerve quits in the GI tract, they get constipation. Now, why does the constipation alternate with diarrhea? Because in the GI tract, you can only hold so much feces. As the feces is accumulating, the bowel is getting distended. There is a point you stretch the bowel and it recoils on itself. And when it recoils on itself, you have diarrhea. And then it goes again and you begin to distend. Once you distend to a certain level, it collapses on itself and you get diarrhea. So, diarrhea alternating with constipation is a sign of autonomic neuropathy. Just like orthostatic hypotension. Because the autonomic nervous system controls how your blood pressure is regulated when you get up suddenly from sitting. When you have autonomic neuropathy, you get dizzy when you get up suddenly. So all of these are signs of autonomic neuropathy. Okay? So diarrhea and constipation. But one thing that is unique with amyloidosis is their stool begins to look like clay. So they have this clay-colored stool. Okay? So somebody said, something is wrong with the color of my stool. And what is it? Say, it looks like clay. And you think clay? Say, no. Then you begin to, and then you ask them more questions. Any bleeding? And no bleeding. About 2 weeks ago, I woke up with this red eye, but it went away by itself. But you know what is cool about amyloidosis? Every single organ in the body is enlarged because of the accumulation of this amyloid protein. So they have splenomegaly, they have hepatomegaly. But depending on their body size and stature, you may not be able to feel liver and spleen. But you know what is interesting? The tongue is also enlarged. So when you tell your patient, open your mouth and say, they protrude the tongue and the tongue fills the mouth. You have no way of seeing the back of the throat because the tongue is so big that when they say, it fills the entire orifice. Okay? So that is your clue right there, that this patient may in fact have amyloidosis. You see, under normal circumstances, this is a patient doing their best to do, you're supposed to see the back of the throat from that. But the tongue is so big that it's in the way, right? So that glossomegaly right there. And then pedal edema, but it's non-pitting. Okay, it's like the kind of pedal edema you get with thyroid disease. It's not a fluid edema, it's tissue edema. So it won't pit. You know what I mean by pitting, right?
Yeah.
Okay. Then when you do blood test, you might see anemia, you might see some protein in the urine, but what is another important clue in amyloidosis is when you do the EKG, they have low voltage EKG. Remember that EKG voltages come from cardiomyocytes, right? So if you have a lot of cardiomyocytes, you have high voltage. We call that LVH, right? If you have few cardiomyocytes, you have low voltage, right? In amyloidosis, they have low voltage because the amyloid protein is squashing and interfering with the ability of the cardiac cells. Okay? So, listen to me. They have cardiomegaly, but voltages are small. That is only amyloidosis present like that. Cardiomegaly, but low voltage. How does that work? Under normal circumstances, when you have cardiomegaly, you're supposed to have high voltages. But in amyloidosis, the cardiomegaly is due to infiltration of the amyloid fibrils, not due to increase in number of cardiac cells. So when you do the EKG will show you low voltage, but then you do the echo will tell you, oh no, the heart is huge. So how can the heart be huge when the voltages are small? Only amyloidosis present like that. Okay? Extremely important that you understand that. Okay? And of course, they have peripheral neuropathy. I already explained to you peripheral and autonomic neuropathy. They have no diabetes. So if somebody comes to you that my feet are burning, I feel dizzy when I get up, I have diarrhea that is alternating with constipation, immediately you're saying this is a neuropathy. It's both autonomic and peripheral neuropathy. Say, are you diabetic? You say no. Then you begin to talk to them to see if this could be amyloidosis, because it runs in families sometimes. If it is not, before amyloidosis, you look for toxic exposures, pesticides, insecticides, stuff like that. They can also cause neuropathies. Okay? But I want you to be clear. How does neuropathy present clinically? If it is a peripheral neuropathy, you have numbness or loss of sensation. If it is autonomic neuropathy, you get these orthostatic problems and GI motility problems, constipation, diarrhea, or both. Okay? And that is how amyloidosis presents as well. Okay? Moving on. Any question on amyloidosis? Okay, now let's talk about histiocytosis X. Histiocytosis is a disease. I hope you realize that we're still talking about interstitial lung disease, right? So remember, this patient with amyloidosis may come to you with shortness of breath. And then under review of system, they will give you history of constipation alternative with diarrhea. Or they might give you recurrent red eye or bleeding in the skin. If you never do a good job of reviewing the system, you will never diagnose any of this. You will miss it. And you will overtreat your patients and cause all kind of problems for them with your drugs that they don't need. Okay? Review of system, extremely important. No matter what you do, you must review the respiratory system, cardiovascular system, CNS, GI, and GU all the time. So what is histiocytosis? Histiocytosis is a disease caused by infiltration of body tissues by activated non-malignant white blood cells of the monocyte macrophage line. They used to be known as histiocytes. Okay? The guy that discovered them was Langerhans, so they're also known as Langerhans cells. Forget about that one. There are two types of histiocytosis. There is a single organ type and there is a multi-systemic type. The multi-organ type is seen in children. Only two types of them, Lederer Sewage and Hansula Christian. Pediatrics, you deal with that one over there, but I'm an internist. I don't touch kids. So, because I'm talking to you about interstitial lung disease, I'm going to focus on pulmonary histiocytosis X. Okay? It is also known as pulmonary Langerhans cell histiocytosis. It is a smoking-related interstitial lung disease. That should ring a bell, because generally we don't associate smoking with interstitial lung disease, do we? No, we don't. We associate smoking usually with COPD. Now I can tell you that which of the following lung diseases is associated with smoking? Interstitial lung disease, COPD, none of the above, all of the above. Good, right? So it's a smoking-related interstitial lung disease, and you will have it if you exceed 20 Parkins. And you all know how to compute Parkins, right? Good. When you do the chest X-ray, before you do chest X-ray, unfortunately, sometimes they can present with spontaneous pneumothorax. Because you see what happens with histiocytosis is that the alveolar wall, they collapse, they break down. So instead of having alveolar, you have these cystic air spaces, right? And sometimes when they're closer to the surface, they form blebs and blobs, right? And those can rupture. So patients with histiocytosis X, pulmonary type, they can come with spontaneous pneumothorax. Okay? And that is a very deadly complication because many times it will be a tension pneumothorax. And they form honeycombing of the lungs. You don't see honeycombing on chest X-ray. You have to order CT scan of the chest to see honeycomb. You know what I mean by honeycombing, right? The collapse. Remember we talked about it. Well, I didn't call it honeycombing, but it is what it is. Remember, alveoli is supposed to be divided into little cavities like that, right? That is a normal alveoli. All of these are air spaces, right? These are alveolar walls, right, in the lungs. When you have the breakdown of alveolar walls and the collapse of those airways into these cystic spaces, right, and you have them happening all over the lungs, that is honeycomb. It begins to look like honeycomb. You know what honeycomb is, right? You mean the behinds?
Yeah.
All right. So you don't see honeycomb on chest X-ray, but you will see it on CT scan. Do you see the honeycombing on the CT scan? Those cystic air spaces. Sometimes they can rupture and give you pneumothorax. Okay. So if the way I will paint a picture for you here is a 48-year-old smoker with say 28 park years present with suddenness of shortness of breath. And I'll tell you, physical examination, trachea is in respiratory distress, trachea is deviated to the opposite side, the breath sounds are absent on the right side. You know this is pneumothorax. But then I won't ask you to tell me whether it's pneumothorax. I expect you to, first of all, diagnose the pneumothorax and then connect that pneumothorax to this young guy with these park years that doesn't have any history of COPD and give me a diagnosis. I will tell you, is it acute pneumonia, histiocytosis? I'll give you a bunch of other crap. Okay, then you have to figure it out. Okay? So histiocytosis, something you must know, spontaneous pneumothorax, a smoking-related interstitial lung disease. Those are the two most important information on histiocytosis. It's a smoking-related interstitial lung disease, the only one of it. Okay? Remember when we were talking about asthma, I told you if you find infiltrate on the chest X-ray of a patient with asthma, you must think about eosinophilic pneumonia, right? Good. Eosinophilic lung disease. Eosinophilic pneumonia is a type of eosinophilic lung disease. Eosinophilic lung disease is a group of diseases characterized by infiltration of the lungs by eosinophils. How do you suspect that a patient may have eosinophilic lung disease? They have infiltrate on chest X-ray. They have eosinophilia on the CBC. Those are the only two clues you have, because unless you recognize pulmonary infiltrate and peripheral eosinophilia as clues For eosinophilic lung disease, you will not order the high resolution, the bronchoalveolar badge that you need. And you will not refer them for lung biopsy either. You have to recognize the infiltrate and the eosinophilia, right? Now, usually you will find this eosinophilic disease whenever there is obstructive lung disease in patients with Church-Strauss. Another name for Church-Strauss is eosinophilic granulomatosis with polyangiitis. Okay? Eosinophilic granulomatosis with polyangiitis. Basically, it's the vasculitis. Okay? And allergic bronchopulmonary aspergillosis. Do those conditions sound familiar to you? Yeah. Exactly. Those are differential diagnoses of asthma patients with infiltrate and elevated eosinophils. Okay? Remember I said that? Okay, good. Now, the one that is interesting that you need to know about, because we train you to be a world-class clinician. You're not only going to see patients in Hollywood and Westwood, you're going to see them all over the world. So you need to know some things. Do you know about roundworms?
Yeah.
Okay, you know the stages of roundworm. So the way it works is you eat something that is contaminated with the egg of roundworm, right? Maybe you eat from a truck, right? And then you inject the egg. In your gut, the egg develops into a larva. That larva, you know what it does? It enters into your circulation, right? And enters into a vein. From the vein, it makes its way to the right ventricle. Then it ends in the lungs. Once it is in the alveoli, it exits the circulation into the alveoli space. And it begins to migrate. It's going back to your throat. All it wants you to do is to swallow. Once you swallow it, it now goes back into your gut as an adult worm. Right? When they are in that transit through the lungs, they can cause inflammation of the lungs. Inflammation of the lung that is triggered by nematodes in transit, the larva, is what is called Loeffler's syndrome. So you're likely to see it in a recent immigrant or somebody that patronizes these vendors that are not licensed. In California, you're supposed to get a license. And part of the process you go through to get food license or food vending license is to submit your stool sample. And they look for the eggs of these worms in your stool to make sure you don't have that parasite. If you do, they will refer you to the doctor, you get treated. Then you can sell food to people. But if you buy tamales in the nooks and corners of the city from everybody, then you are likely to end up with lupus. All right? So when you see somebody that looks like they could be doing that, you ask them, do you eat from the food truck or from people that sell food on the street anyway? They say, oh yeah. And there's a woman that like a tamale. The best tamale in Los Angeles is sold by one woman right there on Central and 120th Street. You need to try it. You need to try that tamale. It's the best tamale. I don't know if she has ascaris in her school. She has the best tamale. You know, it's not a big deal. I mean, just ask, and if it is true, treat them for the woman, and tell them to bring the woman too. Right. So eosinophilic lung disease is two groups. The one from Loeffler's and the one with obstructive lung disease. They are easy to tell apart. Because the one from obstructive lung disease, your patient will come to you with that asthma or the allergy. You know that is the problem. Okay? Okay, moving on. Now let's talk about alveolar proteinosis. It looks complicated, it's very simple. I can dismiss it in one sentence. Surfactant is produced in the lungs, right? To make it easy for the lungs to inflate. Under normal circumstances, One group of cells produce the surfactant, the other group clears it. When that process is not working, either they are making abnormal surfactant that cannot be cleared, then the surfactant accumulates inside the alveolar space and becomes a problem. That is what alveolar proteinosis is. It just means accumulation of proteinous fluid inside the alveolar space. And that fluid is usually the surfactant. It's a normal product intended to make the lung expansion easy. But when you form a mutant form of it that cannot be cleared by the macrophages, then it accumulates. And when it accumulates, it causes problems. Okay? And that is what the diagram is telling you. The type 2 cells, they are the one that line the cells. The alveolar type 1, they make the surfactant. The alveolar type 2 cells, they stimulate the macrophages. Macrophages, under normal circumstances, they will take up the surfactant and destroy it. But when you have problem with the macrophage maturing, so they cannot do what they're supposed to do, or the surfactant they're supposed to break down is not the regular kind, so they don't have the right enzyme, so they swallow it, but they can't break it down. So they become like foam cells. Just like the same thing that happens in coronary artery disease, when the macrophages phagocytose cholesterol and they can't dispose of it, and they get blown up by the cholesterol and begin to obstruct processes and blood flow. So the same thing happens in alveolar proteinosis. Something is wrong. The cells that are supposed to break down the surfactant lipids are not able to do it, either because they are not mature or the surfactant is abnormal. So the surfactant then accumulates within the alveolar space and then causes all this problem. It looks like pneumonia. Look at it. The only difference is that it has this butterfly wing infiltrates, sorry. And usually that's what I just described to you is the primary type. Sometimes that can happen in response to bone marrow transplant, leukemias, some infections, weird ones like pneumocystis and nocardia, some pneumoconiosis. Even good pasture syndrome sometimes can present like that. Okay? But the reality is that your patient will come to you like a normal pneumonia. So you will call this one, this is the one they will call in the emergency room. Oh, she has a double pneumonia. Whenever you see people or your patients come to you, say, I was in the emergency room last week. They said I have double pneumonia. You should step back and probe. Could this be alveolar proteinosis? Because it presents as double pneumonia. Okay? And the only difference is it's not going to respond to antibiotics. Okay? Most pneumonia will be gone in 14 days. If your pneumonia is not gone in 14 days, you're dealing with something else. Okay?
What do you call it? Double pneumonia?
Double. Double as in 2. Right?
And is it responding to antibiotics?
No, they're not antibiotics. You know. Pneumonias like this will not respond to antibiotics. That is the reason when you do, I really want you to do internal medicine rotation in an inpatient service. Because that is the point. It is when the patients have been touched by family physicians and PAs and nurse practitioners, and they don't know what the heck they want to do anymore, that they refer them to the internist. We are the doctors of doctors. So we now try to figure out what they've done and make sense of the whole thing. You know, and I take pride in saying that. Believe me, you don't know how many times I've saved the neck of these surgeons. I'll tell you stories when we do cardiovascular later lectures in the cardiology. All right? Questions? Yes.
So from what I'm understanding is, so the problem could either be with
macrophages,
or the macrophage not being able to.
Yes, either the macrophage got arrested in the maturation process, so you have a maturation arrest, or a mutant surfactant is formed. Bottom line, it doesn't get degraded, so it accumulates. And when it accumulates, it causes problems.
And like, if the problem is with the surfactant, the macrophages don't necessarily turn into.
It depends. Both of them are possible.
So the,
It could be due to abnormal surfactant production or maturation arrest of the macrophages. Bottom line is that the surfactant does not get degraded, and when it doesn't get degraded, it accumulates in the alveoli. It becomes an alveolar filling disorder. Okay, you remember the list of alveolar filling disorders? Pulmonary edema, pneumonia, pulmonary hemorrhage, alveolar proteinosis. Yes. Okay. Any more questions? We're good? Moving on. I like this disease because of its long name. Lymphangioliomyomatosis. It's a long, beautiful name. Listen, lymphangio just means it's a disease of lymphatics. Leiomyoma means is the smooth muscle that are in the lymphatic vessels. Ptosis is a proliferation of those smooth muscle cells in the lymphatic vessels. So when you put it all together, lymphangioliomyomatosis is a disease characterized by proliferation of the smooth muscle cells of the lymphatic vessels. So the name explains the disease. So you can either remember the name and you know everything you need to know about it, or do it your way. Okay, so that is what that is. That tells you that, and you know, it does not occur by itself. Most of the time it is seen in combination with tuberous sclerosis. And when you see it in combination with tuberous sclerosis, it's called TSC-LAM complex. LAM is the short form of it. Sometimes it occurs by itself. What is interesting about this is that it affects the lymphatics, right? So because it affects the lymphatics, it blocks the lymphatic channels. When it blocks the lymphatic channels, the lymph leaks into every cavity available. So they get chylothorax, chylitis, or chyluria. So the lymph, you remember what lymph is, right? Lymph is the excess fluid that cannot make it back into the circulation at the venous end of the capillary, right? So that excess fluid is supposed to be drained by the lymphatic vessels and deposited back into the circulation by the thoracic duct, right? When you have LAM, none of that is happening. The lymphatic vessels are blocked. So the lymph begins to leak into every cavity, including urine. So these are female patients that will pee fat. They will pee, the commonest thing is when lymph leaks into urine, the urine looks like milk. So somebody comes to you and says, Mike, I'm peeing milk. You know, what do you mean you're peeing milk? So you collect the urine and you send the urine to the lab to do lipid profile on the urine. Okay? That's the way you will know that there is actual fat in that urine. Okay?
and it usually happens in women?
Yeah, usually women of childbearing age. And they get spontaneous pneumothorax. So this is a very rare condition, by the way. It's not common, it's rare. But we like to talk about it because it's fun. How do you do it? And honestly, think about it. If you send urine to the lab and tell them to look for lipid in the urine, they will call you. What's your name again? You want me to look for lipids in this urine? Is there a reason why you're doing that? I say, yeah, there is an unusual disease I think she might have. I think you may have a disease called Lyme. If you explain to them, they will do it. You know, but it's interesting. Everybody seems to have some power in this country, and it's a good thing. Because if you don't explain to them, they don't have to do it. They have to know what they're doing. Okay? So, Lyme, the way Lyme will present to you, the way I will pitch it to you, it will be like a 26-year-old female, non-smoker, present with shortness of breath and abdominal distension. On physical examination, I will give you evidence of ascites. She has shifting dullness. Review of system is significant for milky urine. I can either ask you what is the most likely diagnosis or what is the next logical step in the management. If it's diagnosis, it's none. If it's the step, you have to send that urine to make sure it is fat. That is the diagnosis. Okay, then you make your diagnosis. Okay. Okay, this is the good news. This is the good news. See all these things we're talking about, pharmacosis, LAM, sarcoidosis, vasculitis, all this stuff. It's good to know that the commonest form of interstitial lung disease is idiopathic pulmonary fibrosis. Idiopathic means we don't know what is causing it. This is the commonest one. Okay, so we've talked about all this complicated, highfalutin stuff. Bottom line, the commonest reason your patient will come to you with shortness of breath that you can't explain, and the chest X-ray will show interstitial infiltrate, is because of idiopathic pulmonary fibrosis. It's an insidious chronic restrictive lung disease. The history must be at least 3 months. None of your clues, everything we just talked about, clay stool, ascites, spontaneous pneumothorax, yeah, none of those. It will be silent as grave. The only thing you will know is that your patient is short of breath. So you can take consolation in the fact that you're not likely to miss any of those things. If you don't have any of those clues, almost always your diagnosis is idiopathic pulmonary fibrosis. Some people like for you to establish the diagnosis by doing a lung biopsy. And when you do lung biopsy, this is what you see. You see the interstitial space is replaced by fibrous tissue. Okay? That is idiopathic pulmonary fibrosis. Okay? Don't forget, is the commonest one. The number 2 reason for interstitial lung disease is the non-specific interstitial pneumonia. Is the second most common interstitial lung disease. It is a subacute chronic restrictive lung disease mimicking connective tissue disease. You have to do a biopsy to diagnose this. But there is something I want you to know that I'm going to explain, because when we talk about lung infection, I'll be talking about traction bronchiectasis. And this is where I'm going to lay the foundation for you to understand traction bronchiectasis. Now, you know the lungs have bronchioles in them, right? Think for a minute. If the lung is getting fibrosed, there will be an unfortunate bronchiole that will be pushed and pulled in so many different directions. Fibrous tissue building up can push it. Fibrous tissue shortening can pull it. When a bronchiole is trapped between 2 fibrous tissues that are pulling it apart and dilating it, it forms a bronchiectasis. That means it dilates and becomes like a varicose vein, right? That dilatation is what we call bronchiectasis. We like to differentiate that particular dilatation from a dilatation that is resulting as a result of weakness in the wall of the bronchiole. Because sometimes when you have bronchitis, that is a necrotizing bronchitis, causing a lot of tissue breakdown and destruction, you can weaken the wall of the bronchiole. And that bronchiole with the weakened wall will dilate. That is still bronchiectasis too. In order for us to tell them apart, we call the bronchiectasis that you find in fibrosis of the lung traction bronchiectasis. Okay? That is the only significance of interstitial pneumonitis, the irreversible dilatation of the bronchi, because that right there is the reason the patient will keep coming back to you with pneumonia. Because that dilated bronchiole is going to hold on to stuff. And that stuff is going to get repeatedly infected and inflamed, Okay? So you now know, if I use the term traction bronchiectasis, you know exactly what that is. All right, so what is the bottom line of all this? Nothing. Because pay attention. General practice physician, nurse practitioner, PAs, family practitioners, internists, all they do is identify interstitial lung disease. And once you identify it, boom, you do chest x-ray, you do high resolution CT to confirm your impression. The next thing is the pulmonologist takes it from there, and they do everything else that needs to be done. Unless you find yourself in a pulmonology practice, you will not do most of the things we talked about this morning. Okay? Because it's the pulmonologist that will do all those biomarkers, all those serology tests, all those things. Right? And how would they treat it? See what they do. Everybody get a steroid first. And when that does not work, you give antioxidants. And sometimes we have put people on immunosuppression with azathioprine. And we also sometimes use cytotoxic drugs. I've never used any of these. I'm not a pulmonologist. What I do is when the patients are short of breath, I qualify them from oxygen and I put them on long-term oxygen therapy. And then send them on to pulmonology. They do smoking cessation, pulmonary rehabilitation, and when that does not work, they give them lung transplant. This is the general. But if I know you moved to LA from Mississippi, I will give you antifungals before I send it to a pulmonologist. If I know that you probably have it, or you're from, say you came to LA from Burundi, and you're going back next week, and you don't even have money to pay anybody, I will send you back to Burundi with any of this, if I know for sure that you have interstitial lung disease. Because the commonest cause of interstitial lung disease is idiopathic pulmonary fibrosis. So if I give you antifibrotic, and they are not toxic, colchicine we give to patients with gout all the time. It's an antifibrotic agent, right? And you have a lot of them. Colchicine is the cheapest of them all. Okay? And for patients with LAM, why is LAM so important? Because if you can diagnose it, see what they need. Progesterone, tamoxifen. That is available, right? So that is why we pay attention to those specifics. Even though they are rare, if you can diagnose it, you can really help somebody. Okay? So you see, all that we talked about this morning, you can only treat the pneumonias, the atypical pneumonias, the fungal pneumonias, and LAM. Everything else, you are going to start steroids and send them out. Are you with me? Huh? Idiopathic pulmonary fibrosis. All right? Are we good? Excellent. So let's go. Any question? Yes.
People like to use
This one?
Yeah, so all of those medications are all for infections, and then all of those are.
All of these are antifibrotic.
No, and it's all for IPF.
Interferon, yeah, all of these for all of them. Oh, sorry, I should explain that.
The way you wrote it.
The antifibrotic are the medication. They are all for IPF. It's not just interferon. Any of these can be used for IPF. Okay? Yeah, thank you for bringing that up.
The same for the other ones, correct? Like,
And the estrogens, you can use all this is something. You can use for LAM, you can use progesterone, tamoxifen, or send them and take out their ovaries. Okay? Yeah. Okay, I thought you already learned how to read my slides.
So you did? Well,
Usually it's fast, like you
Yeah.
put it on top and then you list it down.
Ah.
Yeah, last time you said it.
Yeah. You're right. You're right. So usually I would have put IPF over here and list all this medication. Okay. All right. Okay. I'm trying to figure out why did I do that. I don't know why I didn't, but it looks like it makes more sense to put LAM specific treatments. Okay, yeah, I think I'll do that for my next slides. I'll revise it. Thank you. Good. Any questions? Yes.
For first round, is it also, can it be restricted and obstructed?
For what?
Because it came up in the last week's lecture, so.
What? I'm not following you.
Truck Strauss is
Okay, Chuck Strauss here. No. Remember, Chuck Strauss, when I mentioned it in the obstructive, Chuck Strauss itself is really vasculitis, but it's usually associated with allergic diseases. So when you see asthma and chest is clear, no eosinophilia, that's a regular asthma. If you see asthma that is recurring and you have infiltrate of the lungs, you have to look for Chuck Strauss, because that means it may not be asthma, it could be Chuck Strauss. So when I mention it under obstructive, it's as a differential diagnosis, something you must think about when you see asthma, along with eosinophilic pneumonia. Okay? But they are really interstitial lung diseases. You got that? Did I answer the question?
Yeah, I was just confused because on one of the slides from today, it's under obstructive lung disease.
No, when I'm talking about eosinophilic lung diseases, right?
Yeah.
I give you the one where I talk about lung first. You can see that thing. Yeah, that's what I'm saying. That's what I'm saying. Okay, let me make sure I clarify this. Last week, when I was talking about obstructive airway diseases, we talked about reversible and irreversible. Reversible one, asthma, irreversible COPD. Under asthma, I told you whenever you see asthma, simple, no eosinophilia, chest is clean, that is straight asthma. But whenever you see positive infiltrate or eosinophilia in a patient with asthma, you must think about aspergillosis and Chuck Strauss. It is not because Chuck Strauss is an obstructive disease. No, but because Chuck Strauss can present like an obstructive disease when indeed it's really an interstitial lung disease. So today, when I was talking about eosinophilic lung diseases, I gave you two groups, one that is parasitic and one that is related to obstructive lung disease. It's the same thing I'm saying. Only now I'm using asthma to remind you that last week we talked about asthma, and as a differential diagnosis of asthma, you have to remember Chuck Strauss and aspergillosis. And today I'm telling you, yes, we're talking interstitial lung diseases, but whenever you see it within the context of a patient with asthma, that should make you think more of Chuck Strauss. And so it's like two sides of the same coin. Did I help? Okay, good. Excellent. So let's go. Bradley. Restrictive lung disease pattern with increased residual volume is characteristic of which of the following diagnoses? Restrictive lung disease with increased residual volume. A? A as in apple? First of all, do you understand the question? Restrictive lung disease with increased residual volume. Increased residual volume. David?
Myasthenia gravis.
Myasthenia gravis, that's it. Myasthenia, remember, the residual volume means the patient is not able to deflate their lungs. That is usually from a neuromuscular disorder, some paralysis of some sort. Okay? Everything else, pleural effusion, pneumothorax, pleural fibrosis, and pneumothorax will give you, even pleural fibrosis, they will give you reduced or even preserved, actually preserved residual volume. Fibrosis, no, actually, yeah, preserved residual volume. All of them will give you preserved residual volume. Okay, please, I'm using this question to make sure that you understood what we talked about last time. All pleural disorders, residual volume will be preserved. Okay, in pulmonary fibrosis, don't get confused with pleural fibrosis. This is pleural fibrosis. This is fibrosis of the pleura, not pulmonary. If it is pulmonary fibrosis, the residual volume will be reduced because it will be a true restriction, right? But pleural fibrosis, residual volume will be present because the fibrosis is in the pleura, not in the lung. Very important. All right? Okay, Vinny. Which of the following is the commonest type of intrinsic restrictive lung disease?
Idiopathic.
Thank you, David. This is my gift to you from the bottom of my heart.
Cool diagnosis on the left.
Okay, so misconnective tissue disease is what? Thank you. And scleroderma? Gangrene? And dermatomyositis? D. Good. All right. Tolu? 68-year-old female hypertensive diabetic on hemodialysis for end-stage renal disease presents with a one-day history of spontaneous subconjunctival hemorrhage. Review of system is positive for color stool. Which of the following is a likely finding on physical and laboratory examination? Thank you. All right. Emmy, which of the following radiographic features is strongly suggestive of miliary tuberculosis in a 72-year-old recent immigrant with chronic cough? Where is it? Go there? All right. Yeah. Emmy.
Oh.
I thought you said Ali.
Miliary TB.
The upper lobe.
Everybody agree with that?
Yeah.
I thought it was
That's what you have on your slide.
Huh?
That's what you have on
Yeah,
your slide.
it says upper lobe predominance.
I know, I said, but I'm just asking. Any other ideas?
All of the above.
I think it's D. No?
You think it's D? Go back to my slide. Don't you have TB under higher lymphadenopathy? Under higher lymphadenopathy, TB is there, right?
I don't know. There's no TV.
There's no TB under higher lymphadenopathy. Okay, then it's B. All right. So it's upper lobe predominance. Oh, you think I know all the answers? Oh, no. Stanley. Extrinsic restrictive lung disease can arise from which of the following anatomical regions? Extrinsic restrictive lung disease can arise from which of these regions?
Is it extrinsic? I mean, it's like the outer.
Outside of the lungs.
Yeah. So the thoracic cage. Okay, makes sense.
Remember, this is like the third lecture. I keep saying, you can have restrictive lung disease from even pregnancy because it pushes the diaphragm up, right? From pleural, from thoracic cage. Kyphoscoliosis will give you restriction, but it's extrinsic because the lungs is fine, okay? Tarika. So you're going to match this diagnosis with those parametric parameters. Everything is the same except the last column. So you're going to make a decision based on residual volume here. So it looks complicated, but it's very simple. Everything is the same. The difference is in the residual volume. So morbid obesity will give you what?
Normal.
Tarika. Morbid obesity? Exactly. Pulmonary fibrosis?
Or low, sorry.
Myasthenia gravis?
Yeah.
Okay. You're all clear with that? Remember, this thing is very simple. Remember, Residual volume is the amount of air left in the lungs after a maximum expiratory effort. If your patient has muscle weakness, either because of spinal injury, myasthenia gravis, or whatever, they are not going to be able to expire maximally. So their residual volume will be high. If the lung is shrunken and fibrosed, their residual volume will be low. If they have no lung disease, that will be residual volume will be low. I need you to, I'll keep asking you as we go, because I need you to know that. That is extremely important. All right, Eden.
56-year-old male with a history of interstitial lung disease presents with a 2-week history of bloody nasal discharge. Physical examination is significant for ulceration of the nasal septum. Routine urinalysis is positive for blood, and eGFR on the basic metabolite panel was 38 milliliters per minute. Which of the following is a more accurate diagnosis? Wagner's
Thank you.
granulomatosis.
Thank you, thank you. That's a very good idea. So now you read the question and answer it too. Maureen.
Double-blind diagnosis is unlikely in a sick patient with no dog ear infiltrates and halo of the you know what I mean? And chest X-ray.
Sick patient with reticulonodular infiltrate and hilar lymphadenopathy and chest X-ray. Keyword there is sick. Which of the patients you're looking at is not going to be sick? Seriously? Rheumatoid arthritis? Sarcoid. Sarcoid patients don't have any reason to be sick until they are in the last stage where there is fibrosis, remember? They only have that hilar lymphadenopathy, that's it, stage 1, and even some infiltrate most of the time. So sarcoid patients are not sick patients. They come with pain in the joint sometimes. But you cannot compare that to histiocytosis, really sick people, rheumatoid arthritis, very sick people, infection, oh, very dead, they're sick. Malignancy, that's cancer, right? So remember that, okay? Chris, any question? Okay, Christian. Just match it. Don't tell us the story. Lupus, what is that?
This is the A.
Good. Scleroderma? Scleroderma is what? C as in cat?
Yes.
Okay. Jogrins?
D.
And polymyositis?
D.
Good. Thank you. Wendy? Are you reading? I can't hear you.
Oh, you want me to read it out loud?
Oh, that is the new thing you guys just started.
48-year-old male recently discharged from the hospital with a diagnosis of pneumonia. Presents with frank
Hemoptysis.
and shortness of breath. Physical examination is unremarkable, but the routine urinalysis is positive for blood, and eGFR on the basic metabolite panel is 28 milliliters per minute. Which of the following is the most likely diagnosis? Would it be D, good pasture?
Thank you. Good pastures. Exactly. Good, good, good. I'm impressed. You know one thing I like about, I really enjoy teaching you guys. I mean, generally, all of you. You demonstrate something that is very remarkable. The ability to actually use the information as you get it. You know, before it used to be that nobody was answering the questions. Because this gives me, this is how I know. Did you learn anything the last 3 hours? if you answer this question correctly, then you really learned what we talked about. You only have to review it for your exam. You know, so now when you do these questions correctly, it really, really makes me feel like, yes, I did home run. All right, Vinny. Which of the following, oh, sorry.
Which of the following inflammatory cells are involved in interstitial lung disease? All of the above.
Thank you. Crystal.
Most patients with chronic cough and shortness of breath, unless with the appropriate diagnosis on the right. Okay. Well, I'm gonna say that one would be D.
Good.
2 would be, what is
It's a plumber.
that?
Asbestos. Good.
Coal miner B.
Excellent.
No worker C. And then Brigham learning.
Thank you.